Hi students, myself Dr. Saiti, team MDSCONQUER. So today's topic of discussion is on general surgery related to salivary glands. Okay, this is given in the chapter of head and neck pertaining to the general surgery. So the histology aspects, the clinical features as well as the anatomy part have already been discussed before. So anat part is being discussed in anatomy, and the histology and clinical features and the important diseases of salivary glands have been discussed in oral medicine as well as OPAT. So this particular discussion is going to enhance and going to focus on the diagnostic as well as a surgical related treatment modalities for the salivary gland diseases. Okay, so if you have already gone through that, you can if you have a good idea of the clinical, the histological as well as the related features before, then you can directly attend this discussion, or else you can just have a glance and you can attend this discussion. Okay, and one more thing, I hope you have done very well in your oral surgery exam that has happened recently. But even if you have not so well, or even if you think that you are not up to the mark, don't get disheartened. Okay, this period of, especially during the lockdown, is like, it is actually challenging for every student, because sitting at home for hours together and preparing is not that easy for everyone. But what I say is this: you have perhaps got the very best time in your hand, right? So excel yourself. The excellence has to be brought up in your hand. The subject, whatever you're gaining now, get the grip of the subject. If you excel yourself in the subject, in your skills and also in your work, obviously the success will follow. Okay, the success, remember one thing, it's not a destination, it's always a long journey. At every step of your life, wherever you go, the success or your goals towards the success, your modalities towards the success will change, right? So it's only your thing. What you can do right now is being excellent on whatever you're learning. That's it. So whatever you're learning now, make a good notes of that. If get the entire concept of the subject wherever it is. If that it's memory based, put again some nice mnemonics and something which is related to that. This will never go waste. If you are excellent in whatever you are preparing, obviously at any cost, inevitably the success will follow you. So be confident, be cool, don't get disheartened. Even if you have done well, don't get overexcited. All the ups and downs are common in a student's life. Unless and until you achieve whatever you want, keep on going. Okay, so at every step of your life, not only talking about the NEET exam, NEET is the first success, definitely, and again the success, that journey goes on till you reach your final destination. Okay, so keep going, students. Now let's start the discussion. So coming to the most commons which have been given in your general surgery, related to general surgery exam also, that include the most common neoplasm. As we know, it is pleomorphic adenoma. And malignant tumor of salivary glands is mucoepidermoid carcinoma. Neoplasm of the salivary gland in children, it's neoplasm of salivary glands in children is hemangioma, whereas malignant tumor of salivary glands in children is the mucoepidermoid carcinoma. So malignant tumor is mucoepidermoid carcinoma, the most common, whereas neoplasm in children is hemangioma. Okay, and the last but not the least, very important, the malignant tumor of the minor salivary glands is adenoid cystic carcinoma. So this most commons are very important, students. Do make a note of it. Okay. So coming to the various causes of the salivary gland tumors, so amongst these, what I feel to be the most important causes are the first one, that is, if there is a constant radiotherapy to the head and neck region, then that particular patient can develop the mucoepidermoid carcinoma of the salivary gland. So this is one of the most common related to head and neck, and also the Epstein-Barr virus infection for the lymphoepithelial carcinoma. Apart from that, all these are the other causes. Just have a look whether it could be exposure to silica, whether it could be increased risk in females with early menarche, whether it could be trisomy 5 in primary mucoepidermoid carcinoma of minor salivary glands, and also the translocation involving the chromosome 11 in mucoepidermoid carcinoma. So these two are related to mucoepidermoid carcinoma, and polysomy of 13 and 17 in adenoid cystic carcinoma. So these are the various causes. So just have a look. So coming to the important aspects again is the best diagnostic modality for a parotid swelling is an FNAC, that is fine needle aspiration cytology. Okay, it's the best diagnostic. Whereas open incisional biopsy is actually contraindicated. Why? Because it can cause tumor cell implantation as well as formation of the parotid fistula. So that's the reason the open incisional biopsy is contraindicated. And the best investigation is the MRI. But if they ask which is very economical, cost effective investigation for salivary gland neoplasms, then you have to go for ultrasound. Okay, it is actually not that clear when compared to MRI, but it is very cheap. MRI is very costly, whereas ultrasound is very cheap. So if they ask in that perspective, you have to go for ultrasound, or else ultrasound is not that good when compared to MRI. MRI will clearly give the anatomical structures, also the perfect delineation of the structures and related to the anatomical structures also will be given. So MRI is perhaps the best imaging investigation. Okay. Whereas ultrasound can only differentiate whether it's benign or malignant. It cannot correctly give the anatomical landmarks, and also the perfect structure of the tumor is not given in an ultrasound. If it is homogeneous, it's said to be benign. If it is heterogeneous, it's said to be malignant. So it is like that. So if they ask the best imaging modality, you have to go for MRI, provided it is costly. If they ask which of the following is very cheap or cost effective or economical modality for salivary glands, then you have to go for ultrasound. Okay. So coming to the famous tumor of the salivary glands, which is the pleomorphic adenoma. We know it's the parotid gland, the superficial lobe or the parotid tail is the common site for that, and it is encapsulated, but it has finger-like projections. That's the reason enucleation should not be done. If it is done, then it causes recurrence. So this point is very important. So enucleation is not the treatment modality. Next, FNAC is diagnostic of the parotid swelling. Treatment aspect is the superficial parotidectomy. Okay, this dissection is actually made on a patis fascio-venous plane. I will be explaining that further. And commenced at the posterior inferior border of the parotid gland, whereas the main trunk of the facial nerve is found out. So here only the superficial lobe of the parotid gland, where the tumor is not involving or encroaching the facial nerve, that can be removed. So most common treatment for the pleomorphic adenoma, the treatment modality is the superficial parotidectomy. Excision of the whole gland is done if it is involving the submandibular gland. If it is a parotid gland, only the superficial parotidectomy. If it is a submandibular gland, then the whole gland is being removed. Okay. So the complications of the pleomorphic adenoma could be slight malignant change, about 3 to 5%, which is called as carcinoma ex pleomorphic adenoma. Next is a recurrence, if particularly after the enucleation. So if enucleation is done, there is more chances of recurrence. Okay. So these are the important points. Next, you can see here, this is a patis fascio-venous plane. Okay. So as we know, the parotid gland has a superficial lobe and a deep lobe that is separated by a H-shaped isthmus, which is a granular tissue. It is H-shaped, as you can see in the picture. Okay. So here this plane is called as a patis fascio-venous plane. Okay. Here is a place where the branches of the facial nerve will come and lies there. Okay. So here patis fascio-venous plane has the branches of the facial nerve. That's the reason the surgeons use this plane for performing the superficial parotidectomy, and they remove the superficial lobe. Okay, where the tumor lies in. So this is how you have to have a look. So this is also called as Petty's operation. So superficial parotidectomy also called as Petty's operation. So we can see, as in the pictures, the superficial and the deep lobe is surrounded by H-shaped isthmus, which is a glandular tissue wherein the branches of the facial nerve lies in. So this plane is being used by the surgeons to remove the parotid tumor. That's the thing you have to remember. Okay. So coming to the picture, as you can see, so as they can, the incisions are given and the superficial lobe is separated and the facial nerve will be there like that, as you can see. Okay, so that they can preserve the main trunk of the facial nerve. So this is the most important parotid gland treatment or parotid tumor treatment, that is superficial parotidectomy, also called as Petty's operation. So we can see most of the benign tumors, they are actually lie superficial to the facial nerve. As you can see, this yellow thing is a facial nerve, so they lie superficially. So when they perform this Petit's operation or superficial parotidectomy, they remove this off and they preserve the main trunk of the facial nerve. If it is inside, you can see if it is inside or in the deep lobe or and also encroaching the facial nerve, then superficial parotidectomy will not be that effective. Okay, so but most of the parotid tumors or most of the benign parotid tumors occurs in the superficial lobe, so the best treatment modality is perhaps the superficial parotidectomy. Okay, so the incisions which are being given are these incisions, students, very important. So you have to go for this, which is modified Blades incision. So it runs like this, as you can see. So from the ear towards the neck it runs, and then the other incision which is equally important, which is latest followed, is this modified facelift incision. So it runs below the pinna of the ear and little towards back of the ear, and it runs down. So they can post these pictures and they can ask. So this is a traditional facelift picture, as you can see. So these two are very important, the modified Blades as well as a modified facelift, also called as the minor parotidectomy incision. This is also called as a minor parotidectomy incision. So these two are very important. So they can post a picture and they can ask the name of the incision. So have a look. So coming to the radical parotidectomy, so in case if I said very rare, if the tumor occurs in the deeper lobe, then it involves the resection of all the parotid gland, even along with the elective sectioning of the facial nerve, usually to the main trunk. Okay, so this is rarely done because rarely the tumor occurs in the deep lobe or encroaching the facial nerve. So the most common treatment modality for the parotid gland tumors, especially like pleomorphic adenoma or WARTHIN'S tumor, is superficial parotidectomy, because the tumors mainly occurs in the superficial lobe. So the surgeons take that Petit's plane as their guidance, and based on that plane they remove the superficial lobe and they treat the disease. After removal, they give any muscle graft from the nearby sternocleidomastoid area and then they do the grafting. So this is how it is done. Okay. So in order to reconstruct the face and the structure of the parotid area, though, they do the grafting. So that's it, students. Next, coming to the WARTHIN'S tumor. So we know it is the second most benign tumor. It is common in males, that you have to remember. It's not common in females, it's more common in males. Okay, and we know it is derived from the salivary tissue inclusions in the lymph nodes. Okay, so that they can arise that from the cervical nodes. So it has histologically, if we see that it has a lymphoid component. And one more important thing is it exclusively occurs in the parotid gland. It is exclusively occurs. So which of the following tumors exclusively occurs in the parotid gland? Then it is WARTHIN'S tumor. Okay, almost towards the angle of the mandible. It occurs lower portion of the parotid overlying the angle of the mandible. Next, it consists of epithelial as well as lymphoid elements, and thus it is known as adenolymphoma. Okay, so since it has lymphoid components as well as epithelial, it is called as adenolymphoma. Next, it is mostly associated with smoking. Bilateral occurs in 10% and it never ever involves the facial nerve. Okay, so very important points which we have missed in other discussions, so that have included here. It never involves a facial nerve, it is associated with smoking, and it's also well encapsulated, slowly growing, and never turns malignant. It also never turns malignant, whereas pleomorphic adenoma has 3 to 5% of getting turned into carcinoma ex pleomorphic adenoma. WARTHIN'S tumor never turns malignant, it never involves a facial nerve. And the double layer lining of the cells is distinctive, with the palisaded layer of columnar cells resting on the cuboidal and the polygonal cells. This you can remember if you want. So these two lines are very important, do remember. And FNAC is the best diagnostic. Superficial parotidectomy is a treatment modality. Okay. So next, coming to the most common malignant tumor is the mucoepidermoid carcinoma. So it again has a low grade and a high grade. So these are the differentiating features. So low grade, it is well circumscribed, having cystic mucinous material, whereas the high grade is grossly infiltrative and has less tendency to form cystic, or it is hard tumor. Next, mucin producing cells are predominating. Here the squamous cells are predominating. This is well differentiated, this is poorly differentiated. This is more common in children, actually this is less common. Okay, so these are the differentiating features. So treatment of choice for the low grade type of the mucoepidermoid carcinoma is either superficial or total parotidectomy. Here it is total parotidectomy plus or minus the radicular neck dissection. So if there are lymph nodes involved, then even those lymph nodes have to be dissected. Okay, so these treatment modalities as per the surgery point of view are very, very important. So do make a note of that. These two, the one which I have highlighted in red color, do make a note of that, and the others also you can just make a note. Okay. So coming to the adenoid cystic carcinoma, this is the most common malignant tumor of the minor salivary glands. So it is minor salivary glands, and it has, we know, perineural invasion. It is the most commonly tendency to invade into the perineural tissues and also lymphatics, thus causes pain, which can be a prominent and a early symptom, and also has facial nerve paralysis. So patient can present with a pain as an early symptom. So based on that, you have to answer that patient has complained of pain and has developed a swelling in the intraoral minor salivary glands area. So the questions can be asked like that. Okay, then it's the second most malignant tumor, second common most after the mucoepidermoid carcinoma. But for the minor salivary glands, it is the most common. Okay, next, it has the neurotropic properties. It also involved nerves are mostly the facial nerve, followed by the V3, that is mandibular division, and the maxillary divisions of the trigeminal nerve. You have to remember this. And the site of origin is usually the minor salivary glands located especially the hard palate, followed by the sinonasal tract. So this you have to remember, students. Okay. So next, again important, is the skip lesions. So skip lesions means it will not involve continuously, it will be like skip here and there. Okay, so skip lesions along the nerves are actually common, because of which the treatment is very challenging, and the treatment usually tends to fail because difficulty in treating the full extension of the invasion. It is not continuous. So they can ask which of the following tumors of the salivary glands have skip lesions, then you have to go for adenoid cystic carcinoma. Okay, which of the following is really challenging and difficult to treat full extent because of the skip lesions, even that you have to answer for adenoid cystic carcinoma. Okay, and also it can grow along the Havisarian system of bone without showing the bone destruction, one more important point, and it is a tracheous tumor as it appears to be benign even when it is malignant. So it is actually betrays, it cheats the surgeon. It appears to be benign, but even when it is malignant, it appears to be benign. Okay, sorry. So that is very important. So best diagnostic modality FNAC, high incidence of distant metastasis is there. Okay, and radical resection, even if it appears to be benign, the radical excision with largest cuff of the normal tissues which is surrounding the borders of the tumor is very important. Though it is benign, you are not supposed to go with simple superficial parotidectomy. The radical resection has to be done, okay, because it is poorly encapsulated with infiltrating nature. So along with the normal tissue surrounding that, the entire tumor has to be, entire gland which is affected has to be removed. Okay, so very important treatment modality you have to remember. Okay, this one, that very important, the radical resection is very important, and post-op radiotherapy should also be given if you feel the margins are positive. The margins are positive, the post-op radiotherapy has to be given. So as per the surgery point of view, the skip lesions is causing a treatment failure, number one important point. Number two, it is very tricky tumor, it is very cheating tumor because it appears to be benign even when it is malignant. Next, third important point, the radical excision along with the normal tissues has to be done even if it appears benign, because it is purely encapsulated with infiltrative nature. The last one is post-op radiotherapy has to be given even if the margins are positive. That's it. So coming to the very much important key points, students. So the malignancy varies inversely within the size of the gland. So malignancy, mostly the minor salivary gland tumors are malignant, okay, whereas the benign tumors common in parotid gland, right. So but malignant tumors are inverse. Next, the parotid gland 25% are malignant, submandibular and sublingual 50% are malignant, whereas minor salivary gland 75% are malignant. Okay. Open surgical biopsy is actually contraindicated because it can cause tumor seeding of the tract. So, remember that the surgical biopsy, open surgical incisional biopsy, as we have discussed, it is contraindicated. Next, most common salivary gland tumors, mostly the salivary gland tumors are radio resistant. Okay. These are the other important key points that you need to note. Okay. So, this one and also the malignancy of related to the specific glands of salivary glands. Next, the last very important is a boron neutron therapy has been used in management of unresectable salivary gland tumors. So, they can ask as a true or false statements. So, do have a look of these students. Okay. So, why are they radio resistant? We know the totally highly differentiated cells which has least mitotic figures, which are least dividing, are always radio resistant, whereas the fastly dividing cells, okay, they are not, they are radio sensitive, they are not radio resistant. So, that is the reason they are salivary glands are actually radio resistant and they are not radio sensitive, because they have less dividing cells. Okay. Next, coming to the indications of radiotherapy. So, these are the various indications that could be high grade tumors, the large primary lesions, wherever there is perineural invasion, bone invasion, cervical lymph node metastasis, and also positive surgical margins. Okay. No role of chemotherapy in salivary gland tumors. This point very important, due to incomplete and short-lived response without any survival advantage. So, there is no role of chemotherapy as such. So, surgery followed by radiotherapy is important. So, these are the indications of radiotherapy and there is no particular role of chemotherapy. So, do make a note. Next, coming to the surgery, parotid gland malignancies. So, coming to the treatment again. So, superficial parotidectomy with preservation of the facial nerve, and total parotidectomy with nerve preservation if deep lobe is also involved. Okay. Next, so if it is parotid gland malignancy, the surgeries include these. So, while preserving the nerve main trunk, even it can be done. So, if deep lobe is involved, then entire superficial and deep lobe has to be removed with nerve preservation, whereas superficial parotidectomy is the preservation of the facial nerve and only superficial lobe is being removed. Then other salivary glands, en bloc excision of the tumor involved the gland, and neck dissection of the lymph nodes if they are clinically palpable nodes and in high grade malignancies. Okay. So, coming to the various complications of the parotidectomy. So, as you can see here, so it could be the facial nerve paralysis and also sensory abnormalities associated with the sacrifice of the greater auricular nerve, parotid fistula. Okay. So, Newman and Seabrook operation can be done. So, in order to reconstruct the duct, that we will be discussing next slide. Fraze syndrome. So, we know the Fraze syndrome, there will be gustatory sweating. So, how it is being diagnosed is a minor starch iodine test. So, it is also called as auricular nerve temporal syndrome. Okay. So, here minor starch iodine test is that where the affected area of the face is being painted with the iodine and then it will be allowed to dry. After that, a starch is being applied on the face and the starch turns blue on exposure to iodine if there is a sweat. Okay. So, in presence of sweat, the starch will turn into blue. So, that is the diagnosis for the Fraze syndrome, and the treatment you can give any antiperspirants, botulinum toxins, and also surgical interruption of the secretory fibers by tympanic neurectomy in non-responding cases. Okay. So, these are the various complications and the respective treatment for the Fraze syndrome. So, this is a Newman and the Seabrook operation, as you can see. So, here first the dilated end of the transected duct, and this is the proximal end of the transected duct, as you can see, and then in order to reconstruct the duct, a stent will be placed, a silatic stent which is red in color, you can see, that will be placed. So, this is operation that is done in order to preserve the duct if there is a fistula that is formed as a consequence of parotidectomy. Okay. So, coming to the major surgical landmarks. So, even these are important for the surgeon. So, it is tympanomastoid suture line, which is the most common surgical landmark. Here you can see that is a tympanomastoid suture line. Okay. here, TMS, as you can see there, this one. Okay, and then the tragal pointer, the posterior belly of digastric, the retromandibular vein, as well as a styloid process. So these are the major surgical landmarks. So coming to the other key points, only we are almost close. So lingual nerve, this is not related to tumors as such, but in general the key points. So lingual nerves lies in close association with the duct of the submandibular, that is a WARTHIN'S duct. So it is more prone to damage during submandibular gland surgery. Okay, and if a stone is proximal to the lingual nerve at the hilum of the gland, then stone retrieval via intraoral approach should be avoided, because there is a high risk to damage that lingual nerve there during the exploration in the posterior lingual gutter. Okay, that's the reason. If it is closely associated with the lingual nerve, so we are not supposed to do it, retrieve the stone via intraoral approach. So these are the important points. This is one of the important point. Next, the stone is actually removed by giving an incision over the stone in the long axis. So directly over the long axis it can be given, incision can be given, and it can be removed. Excision of the submandibular gland when the stone is present in the gland. If the gland has a stone, then you have to excise the submandibular gland. And for Sjogren's syndrome, the minor salivary gland biopsy is always the diagnostic. So it is very much essential to go for a diagnosis for the Sjogren's syndrome. So these are the various key points. Coming to the last, it is Ackermann's tumor, which is a variant of well differentiated squamous cell carcinoma. Okay, that can develop in any mucosal surface of the upper respiratory and the digestive tract. It's also called as verrucous carcinoma, and the risk factors include the frequent use of tobacco and a HPV infection. So Ackermann's tumor is nothing but like a verrucous carcinoma, especially in the upper respiratory and the digestive tract. Okay, so far it is simple.